Okay, you guys, I'm sure that some other folks will be joining us as we continue along here, but in deference to everyone's time, knowing we have a lot of information to cover, both in terms of sharing some information and also hearing back some feedback from everyone that's here, I just want to welcome you. Thank you for giving your lunch hour to such an important topic on a day that's quite a bit sunnier and nicer than those that we've experienced the last several. My name is Kara Murphy. I'm the president of the DuPage Health Coalition. And it is our pleasure to share with Northwestern and with DuPage County Health Department in hosting this event for our human service community. I want to just provide a little bit of introduction for the two speakers and also a thank you to Mila Sagalas, who's going to be helping us to facilitate this event. Dr. Rashmi Chugh is going to start with a presentation and some important slides to provide an overview and make sure we're all on the same page. Dr. Chugh is the medical officer of the DuPage County Health Department, one of many hats that she wears, has actually been in that role since 2003 with the health department. Sure, you could not have anticipated, Dr. Chugh, the year that you would be having. Also joined by Dr. Kevin Most, who also wears a number of hats. Kevin is the Chief Medical Officer and the Senior Vice President of Medical Affairs for Northwestern and the West Region Central DuPage Hospital. I am also biased because Kevin is also the longtime founding board member and chairman of the DuPage Health Coalition Board. So very glad to have you in both respects. With that in mind, I'm going to share, we will want to invite any questions that folks have. A number of people submitted questions prior to this event. We'll do all we can to talk about some of those that came up most commonly. Would also welcome questions to be placed in the chat. We'll do our best to address all of those that we can. Those that we don't get through, we will follow up and make sure that people have that information as a takeaway at the end of this meeting. So rest assured on that front. With that, I will turn over to Rashmi, and I think that she's going to share some slides as well as presentation.
Thank you so much, Kara. Can you hear me all right? Great, thank you. And thanks, it's a privilege to join you all today and be on the panel with Dr. Most, and thank you, Mila, for facilitating. And I think Kim from our team is going to be bringing up the slides, I believe. And as we start, I know we will be sharing the slides, so please don't fret, since we'll be going through some of the content pretty quickly to get to really why we're all here is to try to address questions and concerns. So with that, next slide, please. So certainly we're here to talk about COVID-19 vaccines, but starting with what we know about COVID-19 and what we don't know. We know that it causes that COVID-19 infection causes a range of illness, including many people who have no symptoms. 40 to 50% of cases are believed to have no symptoms, ranging to severe outcomes leading to hospitalization and death, tragically. We don't know how it'll affect each individual person, but we do know that there are some groups of individuals who are at greater risk of severe outcomes, such as the elderly and persons with underlying medical conditions. Next slide, please. And we also know what works in preventing COVID-19 absolutely consistently and correctly. Wearing a mask, a well-fitted mask that covers your mouth and nose, as well as physical distancing and avoiding crowded spaces or indoor gatherings, particularly mid-size or large. Indoor gatherings should still be avoided at this time, and practicing good hand hygiene and important cleaning and disinfection of environmental surfaces, especially high-touch surfaces, is very important. And then, of course, for everyone to get their COVID-19 vaccine as they're eligible and as it's their turn. Next slide, please. So we're hearing a lot about variants, particularly variants of concern of SARS-CoV-2, or the virus that causes COVID-19. And the nature of variants is such that the more infection, the more number of people who are infected, then the more viral replication we have. And that lends itself then to greater likelihood of mutation, which can result in these different variants. And some variants can be harmless or might be circulating but then disappear. but some can evolve or devolve into becoming a variant. They transition from being just a circulating variant to a variant of interest to a variant of concern, which we're tracking locally and nationally and globally, and then variant of high consequence. And the variants of concern are the ones that are really on our radar. Still a relatively small proportion of our overall circulating virus, but of increasing concern. And the good news is that the same measures that are effective in preventing COVID-19 as we know it are also effective in preventing transmission. And one of the concerns, of course, is that, for example, the UK, the variant originating in the UK, the B117, is known to be about 50% more easily transmissible than the dominant circulating strain. So all the more reason to be more adherent to the recommendations to mitigate COVID-19. Next slide, please. So this kind of lays our landscape for us with vaccine basics. So we've talked briefly about the severity and the tragic outcomes that we've experienced locally and globally due to COVID-19. And we know that vaccination is a safer way to build protection. What we want to avoid is for infection to continue to rip through our county and our country, and we know that the toll is just too high to have that continue to happen. And the safest way is to build immunity, particularly herd immunity, as we keep hearing about, to at least reach that threshold and beyond through vaccination. It's the safest way, and now that we're so fortunate to have vaccines, it's the quickest way. So, and as I mentioned, the risk of illness and death far outweighs any benefit of natural immunity as well. So there's the risks of infection that can lead to severe outcomes, and we don't even know how long that immunity lasts. And in fact, so far, preliminary studies are showing that the immunity related to, there seems to be a more robust immune response from vaccination, but they're still tracking the duration and durability of that. So that said, COVID-19 vaccination will help protect you and each of us by building immunity without the risk of severe illness. Next slide, please. Again, just we want to make sure we primarily prevent getting sick. And also important to note that people who have been previously infected still benefit from getting vaccinated, because as I mentioned, we don't know how long that lasts. Right now, it's thought to, immunity from natural infection is thought to last at least 3 months per the CDC guidance. We also know that COVID-19 vaccines, they're not developed from a live virus. They cannot give someone COVID-19 infection. And also they will not cause anyone to test positive on a COVID-19 viral test, like a PCR or an antigen test where they're checking for current infection. Next slide, please. So let's get a next slide, please. We can talk a little bit about how vaccines work. And these are basically two of the technologies that were used. There's mRNA vaccines and then viral vectors. And there are some similarities, but basically they both lead to mounting to triggering an immune response. So with mRNA vaccines, there's genetic material that teaches our cells how to make a harmless piece of the spike protein, which is the sort of spiky portion of it gives the virus, it's not across the surface, and it gives it its that crown-like appearance. And so and the other good thing is that this genetic material is broken down after it's read in our system. And that's, like I said, what that once that that cells display this piece of spike protein on their surface, and then the immune response is triggered inside our bodies, which then produces antibodies which protect us from getting infected if we are exposed to the SARS-CoV-2 virus. Very important to note that it does not affect our DNA, and the mRNA does not enter the cell nucleus, and it cannot give someone infection. Next slide, please. So similarly, viral vectors they use the adenovirus, which is the components that are used are non-disease causing, and that's the vector, the vehicle for the information to be passed through, that then again allows the cell to display the spike protein, and then again triggers the immune response to develop protection against the virus. And again, there's no interaction or integration with our DNA, and it also does not lead to infection in a person who's vaccinated. Next slide, please. Oh, I see the question. Yes, the Johnson & Johnson vaccine is the viral vector, and the mRNA vaccines are the Pfizer and Moderna vaccines. Thank you, Kara. So let's talk about the efficacy, which is the effectiveness in the clinical trial. So in that kind of controlled study setting. So we know that Pfizer vaccine and Moderna vaccines have been found to have very high efficacy of 95 and 94% respectively. And they require some, unique storage support, where Pfizer's in the ultra cold and it requires ultra cold storage, and Moderna still requires cold storage and freezer capacity. And they're each a 2-dose series with a 21-day and 28-day time interval. But and they continue to be studied, and we'll talk about that in a minute. But next slide, please. The Johnson & Johnson vaccine that was just authorized more recently also has very high efficacy for not only mild to moderate illness, and similar to Pfizer and Moderna, that is especially effective against preventing severe disease and deaths. Actually, in the study, it showed 100%. It was 100% effective at preventing deaths. It's 1 dose, so it certainly has many advantages from a convenience perspective, and from a storage perspective, because it can be maintained at just normal refrigeration. It doesn't require freezer storage, and this one is approved for persons 18 years and older. Next slide, please. So CDC and others do advise against head-to-head comparisons of each of the vaccines, because they were studied at different times and different populations. But the value, I think, is in this slide is showing the standards that were maintained, and the similarities and the quality of the development of each vaccine. So really robust sample sizes for each, really from around 30,000 to almost 45,000 for each vaccine of volunteers who were participating in each of the vaccine trials, and geographically widely distributed. Pfizer across 39 states, Moderna across 32 states, and Johnson & Johnson was actually studied during the height of the pandemic in 3 different countries, including the US, where over 19,000 of the 43,000 that were studied were from the US. And then as well as also being studied in Brazil and South Africa, where we know we've had variant activity reported from there. Really, I think validating racial and ethnic distribution that either comes close to or mirrors the demographic distribution of our society and our community, which is important to make sure that we have inclusion in our vaccine studies, so that we know, so each person can feel like, has this been studied in people like me? Very important, I think, to have that understanding and belief. And then also across studying different age groups, particularly those that have been found to have severe impact in our the senior population, or even just again 56 to 85 for Pfizer, and then Almost 2/3 were 45 and older in the Moderna study, and then with about 2/3 being in the 18 to 59 age group for Johnson & Johnson. Next slide, please. So how was it that we were able to develop this vaccine so quickly? We've heard about Operation Warp Speed, and while it might inspire confidence, it also can inspire some concern that we want to make sure that it's not at the expense of safety, for sure. Now, the benefits are that researchers were able to build upon and take advantage of existing clinical trial networks. Also, normally, manufacturing doesn't begin until after authorization and completion of the trials, where data have been submitted and then it's authorized and then they say go. But because of the large investment upfront by the federal government, they were able to, if they had a promising vaccine candidate, then they were able to begin manufacturing alongside the clinical trials, or the different phases of the trials. Also, fortunately, mRNA vaccines are faster to produce, and then this FDA and CDC prioritization has been unprecedented. I've never seen, I will tell you the typical timeline for a vaccine to be recommended by the Advisory Committee on Immunization Practices to the point where it's published and adopted and recommended by the Centers for Disease Control and Prevention is usually 4 to 6 months. And here it's been within days, usually within a week, where the FDA Advisory Committee meets, issues their recommendation, then the FDA approves it, and then the ACIP meets, and then the CDC adopts it, all in the span of 5 or 6 days. So it's been really impressive, and showing that how at every level, from the local to state to national, federal level, everyone's really been really dedicating and prioritizing their efforts on getting vaccine out to our communities. Next slide, please. So an important question here is who's paying for the vaccines? And there, as I mentioned, there's been a huge federal investment in funds, and that the benefit of that is that since it's funded by taxpayer dollars, is that no one can be denied a vaccine if they're unable to pay for it. And vaccine providers certainly can bill insurance or pay or Medicaid for or Medicare for the vaccine administration fee to help cover operational and overhead expenses, but individual patients should not be billed, especially payment should never be an obstacle or a barrier to vaccination for any resident. Next slide, please. So very important to understand to help address anyone who's experiencing any hesitation or understandably has concerns about this newly developed vaccine, is what to expect. And before you get vaccinated, if you're thinking about it, you want to learn about the different vaccines and see if you're, what's recommended for you. Are you eligible based on the current phase that we're in? And then when you get vaccinated, very important to, read through the fact sheet and the information that you give. And then also important to make sure you receive a vaccination record card, which is what, where it's documented, what vaccine and what lot and everything, and, which manufacturer, with the date received. And it will also be recorded in the state immunization registry, iCare, but just good for you to have record of that and take a picture of it in case you lose it, just for your own documentation. Now, afterwards, you want to be prepared and understand that you may experience some side effects. In fact, the majority of individuals experience some mild side effects, which it's actually a good sign that your body is mounting an immune response. And they're usually very transient. They resolve typically within 1 to 3 days. And the most common side effects are generalized, such as fever or chills or fatigue. And then you also might experience, just like after a flu shot or a tetanus shot, you might have some soreness at the site of the injection. And again, it resolves within 3 days typically. It's very unusual for side effects to appear more than 8 weeks after vaccination. And also very helpful, there are multiple vaccine safety monitoring systems, and we encourage anyone who's vaccinated to enroll in VSafe, which is the smartphone app where you, at regular intervals or check-ins. And also important for every person who's vaccinated to continue masking, particularly in any setting in public or in the workplace where you're with other individuals where you don't know their vaccination status, and they're from different households. So next slide, please. So just for a moment, wanted to pause on this because we're talking all about the vaccines and, you know, theoretically how great they are, but it's, as Dr. Walter Orenstein has said, vaccines do not save lives, vaccinations save lives. Vaccinations save lives. So that's really what we're all here for, is how can we get vaccines into everyone's arm who would like to get vaccinated and who's eligible for it. Next slide, please. So our efforts in DuPage County really have varied over the years. So this image on the left is from the past, actually from Ohio, the first year in the first vaccination clinic in 1960 of the polio vaccine back then. And you'll see, of course, that was a pediatric vaccine, and there were many families and, you know, closely gathered in line for many hours. And here we are in a pandemic, so we don't have the same ability to administer vaccines that way. So now everything is very spread out, and everyone wearing either, you know, their cloth-based covering or their appropriate personal protective equipment, and by appointment, largely by appointment, to help make sure that everyone maintains safe physical distancing. Next slide, please. So we talked briefly about the different priority groups, and we are currently well into phase 1B. Phase 1A started back in December, and that was focused on really the highest, the prioritization has been determined through risk stratification based on risk of severe outcomes or risk of exposure. So healthcare personnel, and then individuals living in healthcare in long-term care settings. And sorry, Kim, can we go back one slide, please? There we go. Thank you. So we've got phase 1A, healthcare and long-term care facility residents, and then we're currently focused on persons age 65 and older, as well as frontline essential workers, and then we're working our way through phase 1C and then phase 2. And this timeline is based on when we initially established or estimated our timeline, but as we've been hearing in the last day or so, at the federal and state levels, it's a more compressed timeline. So this will likely be adjusted soon. Next slide, please. We're fortunate to have so many amazing healthcare partners who have really stepped up and mobilized in a way that mobilized and coordinated, and you know, it's been a true partnership. And thanks to Dr. Most and Northwestern Medicine, as well as our, you know, all of our health systems in DuPage County, we've established collaboratively this robust network that allows for capacity of over 65,000 doses to be administered per week. Now, unfortunately, so far, we have not yet received that volume of supply, but we're slowly working our way up, and hope to be able to grow our vaccination capacity as supply increases. Next slide, please. And here, actually, this next slide shows how our vaccine supply has fluctuated so much. And you'll see the most recent 2 weeks here are based on projections, but you know, we're anticipating going down again. And for so many providers to be able to vaccinate their residents in the community, we really need a more robust supply, and we continue to advocate and work on that. Next slide, please. Also very important, again, these are just some of the considerations that we look at in determining how to, we look at, and our vaccine providers and health systems are always evaluating to see how we can make sure that we're vaccinating most equitably, particularly to those high need areas, and objectively assessed by the CDC's Social Vulnerability Index. Next slide, please. And that includes different, 15 different social factors, including unemployment, minority status, disability, and you've got, this is the map here that, and actually, Kim, if you go to the next slide, please. We are fortunate to have over 150 providers who are registered and ready to administer vaccine as soon as we have enough vaccine to be able to distribute to all of them. Next slide, please. And fortunately, even with the relatively limited supply at the federal as well as state level, we have been faring well, I think largely thanks to our wide array of providers throughout and health systems in the community. So we are currently over 13% of our residents being fully vaccinated in DuPage County, and at least in our collar counties, we're over the state average as well. So kudos to our collective efforts. Next slide, please. These are just some additional demographics here on the Illinois Department of Public Health vaccination data page that shows the current distribution by race, ethnicity, as well as age and by sex. Next slide, please. And also, registration and vaccination information is available at our website. The link is right there, COVID-19 vaccine. Next slide, please. And then also to help address the digital divide, we've developed a robust call center with dramatically expanded staffing to help address general questions as well as for scheduling, particularly with seniors or anyone who may not have ready access to online registration. Next slide, please. Very important to encourage senior leaders to be vaccine champions and to celebrate vaccination. We're so fortunate to have the vaccines and to have great public health leaders nationally and locally. We're, Karen Ayala, our executive director at the health department, has been modeling, modeling and leading us, modeling excellent behavior and leading us through our pandemic response at a county level. So really important to celebrate that within your organization and within communities with trusted and credible leaders. Next slide, please. So how can you and each of us be a vaccine champion? So important and central to this process to choose to get vaccinated yourself, lead by example, and then start and engage in effective conversations. And then be prepared for questions, not that you necessarily have to answer everything individually, but at least know some reliable sources where these individuals can be referred to. Next slide, please. So here's just an example and a framework for engaging in effective conversations. As always, you want to start from a place of empathy and understanding. Very understandable for people to have concerns for a variety of reasons, either due to so many of the current and pre-existing inequities, as well as the exploitation and unethical practices from decades ago that thankfully have been corrected, but there's still a lot of work to do, a lot of trust to be earned. And so we always want to start with a place of empathy and understanding. So important that to communicate your belief in the vaccine and to give a strong recommendation. Also to help inform with key facts and accurate, clear information, and to listen actively. Next slide, please. So some of the questions that generally it's very important to help address, myths and fiction to make sure people are aware that vaccines cannot give you COVID-19. There's always been that myth for flu vaccine too, that, oh, well, last time I got the flu vaccine, I got the flu. No, it's your body mounting an immune response, or if it was in fact flu, maybe you were exposed to it before, like just the day before maybe, and you were incubating, and so that can also happen with COVID-19 vaccination and infection potentially. But we do know that getting vaccinated can help prevent illness from COVID-19, and that it won't cause you to be positive, to have a positive test that shows current infection. Next slide, please. So getting into some of the questions here, is it safe for me to get a COVID-19 vaccine if I would like to have a baby one day? So for women of childbearing age who are thinking about it. There was a lot of misinformation circulating on social media early as in December and January, which thankfully I know a lot of clarification has been issued now. So basically, there's no contraindication, and for a woman who is pregnant, they may receive or even thinking about conceiving, they may receive a COVID-19 vaccine when they're eligible, and that there is no evidence that fertility problems are a side effect of any of the vaccines, including any vaccine, including COVID-19 vaccines. So just very important to clear up any of the misinformation that's been circulating on infertility being related to COVID-19. Not the case. In fact, through, I think it was last weekend, I heard that on a CDC webinar that through Vsafe monitoring, over 40,000 pregnant women have received COVID-19 vaccine and are being monitored through Vsafe and have not yet reported any adverse events or effects or anything. So that's really encouraging. Is it safe for me to get a COVID-19 vaccine if I'm sorry, next slide, please. There we go, thank you. How long does immunity last? We don't know yet, basically, but the cohorts of the volunteer groups that participate in the study continue to be followed to monitor for safety and now effectiveness in real world conditions. So we anticipate it being at least months, but as the data come in, then that'll help inform the recommendations for if and when a booster shot is indicated. Next slide, please. Is it safe for me to get a COVID-19 vaccine? I'm sorry, we're going back. Sorry, thank you. How will homebound individuals be vaccinated? So this is something, this is definitely a prioritized a population at high risk that we definitely are actively working on serving, and we already have engaged some providers who otherwise are regularly serving either geriatric patients or providing mobile services in different settings and can expand their services, or are providing home health and then can expand services to include COVID-19 vaccine. So we are working with different home health agencies, health systems, pharmacies, and healthcare providers to help, and also exploring opportunities with fire and EMS professionals to be able to safely deliver COVID-19 vaccines to any individuals who may be homebound. Next slide, please. Should clients who have allergies receive the vaccine? So basically, generally yes, but important if you've had any history of severe allergic reaction to any of the known components of the vaccine. Good to have, I mean, that would probably be one of the only contraindications, but in any other situation, even if you have a history of allergies, every vaccine provider is equipped with the medication to be able to respond to any immediate allergic reaction. And for any individual who's had a serious allergic reaction to any food or anything, they are advised to be monitored for a slightly longer period. Instead of the routine 15 minutes, then they would be observed for 30 minutes just in case, so that someone isn't sent off on their way and then develops a reaction. So, but absolutely advisable in the majority of circumstances to proceed with vaccination. Next slide, please. And so similarly, can I get the COVID-19 vaccine if I have asthma? So asthma and underlying pulmonary disease and so many other conditions are actually an additional reason to be vaccinated. And yes, absolutely, persons with underlying medical conditions can receive the vaccine, should receive the vaccine as long as there's no history of severe allergic reaction to any specific ingredient in that vaccine. Next slide, please. So thank you for your attention, and I think we'll transition to our Q&A part of our program.
Thank you, Dr. Chug. Really enjoyed the presentation, and I think you actually answered quite a few questions, but we have questions that were submitted ahead of today's presentation. I'd like to start with one for Dr. Most on testing. And Dr. Most, if you're unmuted and available, we'd love to get you into the conversation here. The question is, if you've received a positive test result, but then shortly after a negative test result, what do you do? And I think this question really gets to a similar question we had brought up. Are there false positives, and how does that work?
Sure. So if you tested positive and then tested negative afterwards, two things could have happened. Could have been at the end of your infection and you were going to test negative in the future going forward anyways. Could it have been a false positive? Certainly. But in all honesty, we all have to realize that a test is a snapshot of what a condition is currently. Really doesn't have that much of an impact going forward. Because even if you were positive and had an asymptomatic infection, we are still going to encourage you to get the vaccine, because we know that those individuals who have had COVID and get the vaccine have a great immune response. And really now you know you are protected beyond what the natural immunity would have protected you for.
Thank you. Similar question to the side effect question about asthma and pneumonia and things like that. Are there any medical conditions that people should be aware of that would make their side effects more difficult, or that would maybe they need to talk to their doctor about before receiving the vaccine?
You know, I'll go, and then I'd love to hear what Rashmi thinks about too. You know, unfortunately, I think the media has blown the side effect profile of this vaccine out of proportion. I can tell you that, you know, when you do a vaccine trial, that was one of the things they looked at, was the side effect. When you're in a vaccine trial, you are asked every single day, what symptoms do you have? Therefore, we knew that we were going to have a large number of side effects in the trial. I can tell you historically, coming out of the trial and going into reality, where instead of 120,000 people, we're talking about millions, that the side effect profile is very, very low and very short-lived. So I can tell people that are hesitant, if one of your hesitancies is about side effects, I can tell you that the side effects from COVID are a lot worse than the side effects from the vaccine.
Dr. Most, could I add on a question to that? And as you, Dr. Chug, talk about it, I think some folks are concerned that there may be long-term side effects and we just don't know what they are. And based on experience with other vaccines, do we have an answer for that?
Yeah, I mean, if you look at vaccines overall, you know, as children, we get about, 18 vaccines under the age by the time we're 18. We know that there are not a lot of long-term side effects for any vaccines. There are certainly some cases, one in a couple 100,000 of individuals who may get something called Guillain-Barré. We haven't even seen that with the COVID vaccinations. So as far as long-term side effects of COVID, obviously we can't say anything because it's only been months that we've been doing this, but certainly if we took all vaccine history, long-term side effects from vaccinations is minuscule when compared to life-saving and, you know, just health and wellness reasons. And I don't know, Rashmi, if you had anything else to add to that.
100% agree. We do not know of any long-term effects with or from COVID-19 vaccination. And as I mentioned, they continue to study these, you know, tens of thousands of individuals who have enrolled, not only the persons who originally received vaccine in the study, but then even those who received the placebo, once it was authorized, were offered vaccination, and then they, on a voluntary basis, are enrolled and continue to be monitored from a safety as well as effectiveness in real world conditions perspective. And so far to date, no long-term effects have been reported. And what we do know is that COVID-19 infection, almost 30% experience long-term complications. We've heard of the long haulers, or, you know, long COVID-19, and it's just, it's a, you know, a real tragedy for those who, thank goodness they survive, but, you know, some end up with disabling conditions that, and, you know, warranting, you know, weeks and months of rehabilitation. And so none of that is experienced with the vaccination. So as we've been saying, vaccination is known to be much safer and can help prevent any of the long-term complications from COVID-19 infection.
So one follow-up to the vaccination, both the Moderna and the Pfizer, is that it's a 2-dose vaccination. And there's a question, what happens if I don't get the second dose?
So if you look at the whole panacea of vaccines, so if Pfizer and Moderna, obviously 2 doses are going to give you the maximum protection. If you get 1 dose and you don't get that second dose, which we are not recommending at all, you will still get 60-65% protection. Everyone looks at Johnson & Johnson and says, I don't want to get that one because it's only 66% effective. And people have to understand 2 things. One is Pfizer and Moderna were tested initially before a lot of variants, where Johnson & Johnson was actually tested during the variants, including the South African variant. Johnson & Johnson also is doing a study on a second dose. So we may see a second dose from Johnson & Johnson, which may get that vaccine up to 90-95% effective. And probably I know that there was a question too about children and when are we going to be vaccinating children? So there are studies going on right now with Moderna and Pfizer. Moderna is looking at 12 to 17-year-olds. Pfizer is looking at 12 to 18-year-olds, with both of them ready to roll out. As a matter of fact, Moderna rolled out yesterday the start of the vaccine for infants 6 months to under 12. So we're going to start to see good data in the summer, early summer to midsummer, on how this vaccine works in children as well.
Thank you. That does answer a couple of questions that came up on child vaccine safety and what the timeline was for that. The next couple questions have to do with antibodies, and people are asking, if I've had COVID and I have positive antibodies, do I still need the vaccine, and if so, when do I get it? Either of you can answer.
I'll throw a quick answer. And Rita Wilson, everybody probably knows Tom Hanks' wife, Rita Wilson, right? She makes the media because both Tom Hanks and Rita had COVID, and they were monitoring their antibodies, and all of a sudden Rita responds and says, oh no, my antibodies are gone. So what we all have to understand is 2 things. Antibodies will come during an infection and wane, but our body has things called T cells and B cells, which remember infections, so that when we see them again, that's when we start making antibodies again. So don't be concerned if your antibodies would drop down below a level where we wouldn't test them or we wouldn't say it's a positive test. The body will remember to make that. Individuals who have COVID, as I said before, we're really recommending that they do get the vaccine. There shouldn't be any vaccine hesitancy there for them. It's kind of like once you've had influenza, I assure you, you're getting in line for the influenza shot the next year just because you know of the illness. So Rashmi, I don't know what else you'd like to add to that.
Yeah, no, thanks. I think you laid it out very well, that there's really no recommendation for pre-vaccination antibody testing or post-vaccination antibody testing or anything. Like you said, it's not an accurate indicator of immune response related to the vaccine or for need, since we know that if someone was previously infected, then as long as they're outside of their isolation period from the initial infection, and as long as they didn't receive any monoclonal antibody or convalescent plasma, in those 2 situations, we would ask that they defer vaccination for 90 days. But outside of that, there's really no indication for pre or post-vaccination antibody testing.
Thank you. And one more follow-up to the antibody questions. Someone had asked if they had had COVID and even had an infusion of COVID antibodies as a part of their treatment. Do they wait that same period of time, that 90 days you just spoke of, before receiving the vaccine?
Yes, that's exactly the situation where if someone had COVID-19 infection and as part of their treatment received an infusion of monoclonal antibody or convalescent plasma, then they should defer their vaccination for 90 days from that infusion. But other than that, then we would definitely recommend that they proceed with vaccination.
Thank you. The next question is about the variants. All 3 vaccines are being tested and research is coming out on how effective they are, but the variants are new, and there's some question of how effective they are against the new variants.
Okay,
well,
yeah, a few things. People think that variants are new when in fact they really aren't new, right? The British variant, the South African variant, they were here in the world in the fall of last year. If you look even at the California variant that just came out recently, it had been there as early as November, December. So we know that the variants are around much longer than you hear about them in the media. We do know that the variants are here now. The South African variant is in Chicago. The British variant is in Chicago. So two things about it. One, we don't know how good the vaccine is against the variants, but we know that some of them are actually lining up very well. But two, this should really be the call to get vaccinated, because if we have enough people vaccinated, we won't worry about variants because they won't spread. So really, it is going to be a portion of keeping the number of variants down to a small number so that we aren't allowing it to spread to a greater number of people.
Okay, excellent. We're going to get to the question about undocumented and ID required at the time of vaccination in just a minute, but there is a question about if this vaccine has an emergency authorization approval. Why is that, and do you think that that will change soon? Or these vaccines, I should say.
Rashmi, go ahead, and then I'll throw in.
Sure. I mean, I think it's called emergency use authorization to help expedite not only the resources to develop and implement the processes to still vet it and make sure it's safe and effective, and then to allow access and get it out there into our communities and then into people's arms, because otherwise, as we know, routine processes can be kind of bureaucratic, I hate to admit, and delay development and access. And so a lot of it is to prioritize, again, the resources and the attention required to be able to expedite access, because we're in a pandemic, which I would say is a global emergency. So that's why it met those criteria for public health reasons. Go ahead.
If I was a public relations person, I would have removed Operation Warp Speed, and I would have minimized emergency use authorization. Both of those, I think, are leading to vaccine hesitancy. People say, the measles vaccine was the fastest vaccine ever made prior to this vaccine, right? Well, classically, forget about Ebola and Zika, but it took 4 years. And people say, well, if it took measles 4 years in 1963 to be made, how could we have made a vaccine this quickly? In 1963, imagine what a computer was like. In 1963, think about trying to distribute and manufacture. Fast forward to now, in 1963, we had 3 companies working on a measles vaccine. Fast forward now, when that virus hit, we had the genetic makeup of it in less than a month, totally decoded. We had 200 companies worldwide working on a vaccine. And the medical technology that has advanced over the last 60 years is absolutely amazing. So although we call it Operation Warp Speed, we really have to understand that this was done very safely, very effectively, very efficiently. And really, I'm really hoping, 120 people on this call, if we were to use normal Gallup data right now, there's 35 of you who are still on the fence as to whether or not you're going to get this vaccine. And as community leaders, people are going to look to you to say, should I get the vaccine? Did you get the vaccine? And that is why Rashmi and I are here to answer any questions and try to dispel any myths so that you can be a community leader and say, darn right, I got the vaccine. And yeah, my arm hurt for a day, but boy, I'm doing my part to protect the community. So.
Thank you. There's a question that came through the chat that asked, is it true that vaccine can affect mammograms up to 6 weeks after being vaccinated? And I don't have specifics on how it affects the mammograms, but I wanted to throw that out there.
That's okay. Yes, so vaccines, when vaccine is given in the arm, it causes an immune response. Part of our immune system response is lymph nodes. So sometimes in some people, the lymph nodes close to the breast, under the axilla in the arm, can be inflamed. So if you did a mammogram, they might see those enlarged lymph nodes and be concerned and start looking more for a cancer diagnosis as well. So I'm not sure, Rashmi, what the recommendation is now as far as delaying or spreading out the two, but I'm sure you probably know.
Sure. Yeah, no, you're right. You can get vaccinated, or you can receive your mammogram like up until you get your vaccination, or you are advised to wait 4 to 6 weeks until after vaccination to receive your mammogram. So it just depends. Again, consult with your provider, see if, because you don't want to unnecessarily delay one if it needs to be prioritized over the other. But just so that the timing is appropriate, so that, like you said, there's not a false positive that then is concerning and you know, unnecessarily. So 4 to 6 weeks between the vaccine dose and the mammogram is advised.
And again, people need to understand that lymph nodes during a vaccine are part of your immune response. It has nothing to do with breast cancer. It has nothing to do with anything else. It's actually what we expect the immune system to do. Kind of like when you get strep throat or sore throat, or you've had kids who have had mono and they get those big swollen lymph nodes in their neck. That is a normal response that goes back to normal when the infection is gone.
Great. Those are great answers. We have a large female audience, so it's all good information. The next question is really about it's something you all may not be able to answer, but it's an important one, is do you think a booster vaccine is something that's coming down the line? And we're sort of learning about the length of immunity and all these things as we move further into our vaccination process, but opinions and educated thoughts on that.
Sure. I'll give you my personal opinion, and Rashmi may disagree with me. I think as you're starting to see variants pop up and you're starting to see some changes here, it's exactly what we see with influenza, right? Everybody knows the influenza shot changes every year, and it changes because of variants through the previous year or variants in the Southern Hemisphere. And that's why we get a flu shot every year, because of the variants. I can see the same thing happening here. And I will say one other thing too, because when you're talking about Pfizer, Moderna, Johnson & Johnson, people are saying, oh, which one should I get? You should get the one, whichever you can get the soonest. Don't handpick. People actually said, I'm going to try to avoid Johnson & Johnson. And I said, I told people, if all three were available to me and I get to choose one, I'm taking Johnson & Johnson. So it's kind of interesting. And same with influenza. We never ask which manufacturer made our influenza shot, and yet we still get all the influenza shots. So that would be my answer. And Rashmi, I'm not sure if you think we're going to need boosters in the future, but I'd love to hear your answer.
I agree with your theory that I think it is very likely that we'll continue to see some shift and drift, you know, in the different variants as we're seeing. You know, some might be harmless, but some may be these variants of concern that persist. And if they do, then that's what we want captured in the next iteration of the vaccine. And it might, like you said, similar to influenza, it might contain multiple strains. Like the flu vaccines are now quadrivalent. They actually cover 4 strains, whereas for many years, the previous vaccines just covered, they were trivalent or had 3 strains. So it just depends on as we said, we'll just wait for the data to come in and, you know, the scientists to review the duration and durability of immunity from the current vaccinations, and then see if and when it's very possible, you know, if immunity is waning and we start seeing, you know, risk of or vaccine. Well, right now, if there's a very small percent of individuals, like we know that the vaccines are 94-95% efficacious, so that leaves 5 or 6% of individuals who might still contract COVID-19. We have seen a handful of vaccine breakthrough cases in DuPage County, and thankfully so far they've all been very mild, very much managed as an outpatient, resolved. And that we know that happens with flu too, with flu vaccine. To your point, Kevin, that I think thankfully, you know, we don't ask. We know that flu vaccination is actually much less effective. It's on any given year, it's 40 to 60% effective, but I'll take those odds. I've been getting my flu vaccine every year for 25 plus years, and no regrets. And also, thankfully, no flu diagnosis to report. But if someone does get influenza having been vaccinated, they're much likely to have a shorter and less severe course of illness. And that's what we're observing in the handful of vaccine breakthrough cases that we've seen, is that they're very mild and transient. And so, so I think depending on the duration of protection that is observed, that I imagine we might have a booster dose recommendation, you know, either on an annual basis, like you said, Kevin, that reflects the currently circulating viruses, and then, or it could be in 3 years or 5 years, or like tetanus, you know, every 10 years. So it just depends on the duration of and the quality of the immune response from our current vaccinations.
Dr. Most and Dr. Chu, thank you so much for your expertise today. I'm going to turn this over to Kara and just mention that if you're not looking at the chat, there was an important question that came up about undocumented residents and concerns there. And Kara did put an answer in the chat, and she can reiterate it quickly if she likes to. And Kim Siebert is going to include some links from the health department's website and FAQs that will really help with some of these questions and providing some very summarized answers. Thank you very much. And Kara, I'm handing it over to you.
Great. Thank you guys so much for presenting so many questions prior to the event, as well as the great questions that you asked during. I did address in the chat and want to say very conclusively that someone's immigration status has absolutely nothing to do with their eligibility for the vaccine, and no one will be turned away for a vaccine for which they qualify because of their immigration status. I know that that's an area of a lot of concern in the community, and we really want to make that very, very clear. To that end, there are a host of different ways. While it is requested if folks have a ID to provide it at the time of vaccination, but there are a lot of creative ways to do that, and it does not need to be a driver's license, and people do not need to be lawfully present. So I want to be reassuring on that. I want to offer one more comment. I know that that some folks on this call may be aware that there is a group working led by the health department, but also co-facilitated by a number of us on this call on health equity and health access issues. It's called HEART. And if there's someone that's on this call that would like to get more involved in our efforts at a community level to promote health equity and ensure that everyone has equal access to the health services that they need and to reduce health disparities, I've put my email address in the chat and would welcome outreach from anyone who's interested in that topic. Would be happy to provide more information and also share information about future meetings. We have already committed and will absolutely share the slides from this event as well as recordings of this event. For others, it would be very helpful for people to share what questions are coming up for them both at the community level and personally, so we make certain that there's a way that we can address those. And I just really want to thank everyone for giving their time to this important topic and for your passion and your enthusiasm in making sure that we can, as a community, get past this scary last 12 months and look forward to a better future. So thank you very, very much for your time and your thoughtfulness.